I'm reading
basically talking about this, Saccadometry.
I'll let you explain.
Yeah,
How's
okay.
that?
So, good afternoon, everyone. Hello. So, my name's Nick Cunniffe. Basically, my background is I'm a general medical trainee in London, but back in the day, I was back at Cambridge, and I did a lot of work, particularly with this gentleman here, Professor Carpenter. It was actually him that was invited to speak today, but due to poor health, he sort of nominated me because I worked quite heavily on the paper as well. So some research that we undertook a couple of years ago now got published this year. So basically that's what I wanted to talk about today. I think that's the best. So basically my topic, the title of my talk today is going to be Saccadometry and how this might be a novel diagnostic tool in diagnosis of Covert Hepatic Encephalopathy. So there's only three things I want to talk about today. Shouldn't take too long. I'm very much in favour of this idea of let's all get off early, go into Rome and have a nice meal. So what I'm going to do is quickly whip through these and then see how we get on. So in order to properly talk about this title, I need to first of all talk about saccadometry, how it's been used in the past, and actually a bit about the basics behind it as well. Then talk about hepatic encephalopathy, again what it is, and some of the pitfalls that there have been in terms of actually diagnosing it in the past. And then tying these two subjects together, I'm going to talk about how saccadometry actually might play a role in diagnosing covert hepatic encephalopathy. So first of all, talking about saccadometry. Now first of all, just need to very briefly explain what a saccad is, and obviously most people's background here is neurology, neuroscience, so most of us will know that a saccadic eye movement is a rapid, what we call gaze-shifting eye movement from one position to another in space, bringing a point in space onto that tight focus on the fovea. This is a sort of typical task we might use. We might use a laser and present a target to a patient there, ask them to fix this laser here, and then after a random period, that will be extinguished and they'll have one peripherally that they'll have to look at, and they will make an eye movement towards that. And if we look at what the eye actually does, the target will move rapidly from one position to another, and then after a short delay there will be an eye movement. That's what saccad is, and that's what we're interested in. Now when we look at this on a sort of a graph of position against time, what we see is something like this. Now the first thing to notice about what's happening on this graph is that first of all here is the actual eye movement itself, and you see this a rapid acceleration of the eye to reach kind of its terminal velocity before it slows down and settles firmly on the target. Now this is actually a very rapid movement, 30 milliseconds. It's an incredibly rapid process. But what's actually perhaps more interesting is the fact that there is this delay, this latency from actually the presentation of the target to the movement of the eye. And that's about 180 milliseconds, but it varies. It can be as low as 120, anywhere up to 300 milliseconds or so, depending on a variety of different factors. So one wonders why actually there is this delay. Now, looking at simple neurophysiology, you can think about the most simple circuits that might be involved in actually making this eye movement, and that involves the brainstem. The eye will pick up a bit of information in the visual world. That information will get communicated back to the colliculus, and sort of simple tests can tell us that that might take about 40 milliseconds at its fastest, allowing for delays in terms of nerve conduction and synaptic processing and so on. Equally, the efferent pathway in terms of making the eye movement is only some 20 milliseconds. So you can see that an eye movement could actually just take 60 milliseconds. The latency between the presentation of a stimulus to looking at that target could only be as little as 60 milliseconds. Obviously, it's about 3 times that, I've already said. So the truth is there's a whole lot more going on. And in order to actually make a decision as to what we're looking at in any particular moment, there's a huge variety of different cortical structures that are involved. And essentially, what we're thinking about is decision time. Reaction time is the time needed to make a decision. So this is a deliberate attempt by the brain to actually decide what it wants to look at in any individual time. Now, this is where it gets a bit more interesting. This is sort of what we can study. Is the fact that if we present a series of different targets to a patient, you saw one of them before with that laser target that we saw. If we do that sequentially, the actual velocity of the eye doesn't actually change. The speed of the eye movement is the same each time. But what varies is the latency, the time between presentation of the stimulus and actually the beginning of that eye movement. That's what interests us. Because if we look at it on a sort of typical histogram, you can see latency plotted here. There's kind of quite a skewed deviation with a sort of lot toward a skew towards the longer latencies. And one wonders why this is. So essentially what's happening is you're linking a stimulus to a response, the target to the eye movement, and what we're measuring is a reaction time. But the brain doesn't really think about it in terms of time. What it's thinking is in terms of a process. And that's some sort of decision process is going on that's happening at a certain rate, and essentially that's the inverse of the latency. So instead, perhaps we're thinking about this wrong. If we look at this on an inverse time axis, we plot inverse latency here, you start to get actually much more of a predictable relationship, and you get more of a Gaussian type distribution, something we can measure, qualify, and analyse much better. Once we get that, once we have that idea set in our heads, then we can start to look at a couple of different features to actually look at the distribution of the saccades. First thing we look at is the median of this distribution, the inverse median latency. Okay, something I'll be talking about when we come on to looking at hepatic encephalopathy in our recent work. And we also look at the spread of the distribution as well. How do we measure saccades? Well, this is something called a saccadometer. This is one of my friends wearing it, but essentially it's a device that's very portable, sits on the bridge of your nose here, and you don't need to have a bite bar or chin rest or anything like that. It moves around with your head. You see these three lasers here. These will predict a target towards the wall, each 10 degrees apart, and then we can run a trial run of say 200 saccades in about 7 minutes. Nice sort of rapid process, and watch as the patient will make eye movements to the different targets. Now the interesting bit is what's happening just here. Because as we look back at the eye, what's actually happening is we have an infrared detectors and sensors that are shining light alternately on each side of the eye using scleral reflectance to actually work out when the eye starts to move. So that's how we measure our saccades. Now this has already been shown to be of interest in a variety of different medical conditions before. For example, Huntington's disease. We find that patients, even displaying symptoms by several years, sometimes display saccades that actually have significantly increased latency. This variable here, mu. Mu is the inverse median latency. So basically, a smaller mu means that your saccadic latency tends to be longer. Okay, I think of it as promptness. You know, your saccades are less prompt. So in this case, if you have Huntington's disease, basically your reaction time slows down. Kind of makes sense. Interestingly, in Parkinson's disease as well, you see a correlation between saccadic latency and decreasing grey matter volume in the prefrontal cortex. Also as well, it correlates with treatments as well, things like deep brain stimulation. We see that our latency slow down in Parkinson's disease, but they can be sped up by treatments like deep brain stimulation. Now, this is perhaps where I come in, is because we started to look towards saccadic latency in the role in hepatic encephalopathy. And a pilot study done a few years before ours showed that it was actually correlated with hepatic encephalopathy. As someone becomes more encephalopathic, their reaction times, their saccadic latency gets prolonged. So let's talk about hepatic encephalopathy. It's just a couple of slides just to outline what we're looking at and why we're looking at it. Well, hepatic encephalopathy is this potentially fatal yet treatable complication of chronic liver disease. And it's believed, I mean, obviously what happens in chronic liver disease, for example, cirrhosis, is you get something called portal hypertension, and the nitrogenous waste products that get produced in the gut get shunted in the systemic circulation and then get conveyed to the brain, and that impairs neurotransmission. Now we grade this clinically with what's called the West Haven criteria from 0 through to 4. 0 is a patient that's completely asymptomatic, nothing detectable clinically to say that they've actually got any degree of encephalopathy, and 4, where they go straight through towards having frank comatose patient. Now, covert hepatic encephalopathy is the subset that we were interested in. This is what no one's really looked at before. Now, this is important, this is quite interesting. Now, remember I mentioned that it's a degree, and in some patients who have cirrhosis, who have no evidence of encephalopathy whatsoever, for example, you get them to put their hands out, there's no liver flap or anything like that, actually a significant proportion, a difficult proportion to estimate, but a significant proportion, between 30 and 70%, some people say, who have no evidence of encephalopathy, in fact actually have a subtle cognitive dysfunction. And this was previously called minimal hepatic encephalopathy, and now it's been renamed as covert hepatic encephalopathy. And it's important because it's been linked to progression to overt encephalopathy to higher degrees. It's been linked to increased mortality and impaired driving. You're more likely to crash your car if you have this subtle cognitive defect. And meanwhile, treatment is possible. Currently, it's assessed for with pen and paper, what we call psychometric tests. But they have a variety of different drawbacks, hence the appeal of introducing a new diagnostic technique in its assessment. So here's a couple of examples of psychometric testing. This is the number connection test, A. There are two different types. Simply, a patient's just asked to get a pencil and go 1, 2, 3, 4. And what we really look at is how fast they do it. Digit symbol test on the other side, a bit more involved. What we're asking the patient to do is essentially to fill in the symbol here correlating to a key up here and work their way along. And essentially you just look at the time it takes to complete this task. However, despite how important covert encephalopathy has been shown to be, very few clinicians actually test for it clinically because these are very time-consuming and subject to various different degrees of bias. They don't think it actually changes their management at all. And this is where we thought saccadometry might come in handy. So that's where we're up to. And that brings us through to me linking these two topics together and thinking about how saccadometry may play a role in diagnosing covert hepatic encephalopathy. And this was the paper that we got published this year. Particular colleagues, like I say, including Professor Carpenter, who's my boss back in Cambridge. So, our hypothesis was that patients with covert hepatic encephalopathy would have prolonged saccadic latency, i.e. they would have slower reaction times when you compare them to those that do not have covert hepatic encephalopathy. So what we did was we went to liver outpatient clinics in Adam Brooks Hospital in Cambridge, and we took 35 healthy controls and 36 patients with a diagnosis of liver cirrhosis. Now, there were a variety of different exclusion criteria. I'm not going to bore you with all of them, but the key thing is that none of them had any evidence of encephalopathy or had previously been treated for it. Hadn't even been considered with them, really. They all were what we would call grade 0. So some of these patients, in theory, would have covert hepatic encephalopathy. Some of these patients would not. And that's what we wanted to find out. So in order to work out whether these cirrhosis patients had covert hepatic encephalopathy, we subjected them to these psychometric tests. Now, the World Congress of Gastroenterology recommends that we use 4 key diagnostic tests: the number connection tests, A and B, the digit symbol test, which is the one we saw on the right, and also a block design test as well. And it's kind of complicated. The wording isn't particularly good, but basically, if you fail 2 tests or more, then they say you're likely to have this subtle cognitive impairment or covert hepatic encephalopathy. And they say you fail a test if your score is more than 2 standard deviations outside the normal range. Basically, if you fail more and more of these tests, you're more likely to have this subtle cognitive defect. But like I say, because of the problems with administering these tests, it's very rarely actually looked for. So, what do? Well, we did these tests on these patients, and we also measured their saccads. And for each participant, we used that saccadometer I pictured at the start, and we measured 200 saccads, and it takes about 7 minutes to perform. It doesn't require any particular skills or expertise. It's very simple. A nurse could be trained to do it in a clinic. And for each saccadic latency distribution, we looked at 2 key features. First of all, the inverse median latency, well, as I said, a measure of promptness. Okay, that's going to correlate with our reaction times, and also the spread of the distribution. How variable is an individual's reaction time? Boring stuff, demographics. Patients had cirrhosis, healthy controls did not. Okay, there were different etiologies we looked at, but there wasn't particularly anything interesting when we looked at the sort of subspecialties, but we would need a bigger sample size, really. This is the key graph, and this is the real take-home message from today. Now, first of all, let's concentrate on this bit here. These are our healthy controls, no evidence of liver disease whatsoever, and these are all of our cirrhosis patients. Now, what we find is that if we look at mu, remember that was our promptness or inverse median latency, we find that there is a significantly reduced promptness between the two. Okay? Basically, what I'm saying is that if you have cirrhosis, you're more likely to have prolonged latency, prolonged reaction times. Equally, if you look at sigma, this is our spread of our distribution, the saccads are more variable as well. The latency is more variable from trial to trial. So we can say here that cirrhosis patients have significantly prolonged and more variable saccadic latency than healthy controls. That was the first thing that we found. Now, the key question I asked at the start was actually referring to this part of the graph here. Okay, these are our patients that we said had covert hepatic encephalopathy when we used our psychometric tests. And these are the cirrhosis patients that did not have covert hepatic encephalopathy using the current battery of psychometric tests. Now, again, what we showed was that there was a significant difference. And again, your saccadic latency tends to be longer if you have covert hepatic encephalopathy as opposed to not having it. So if we use the psychometric tests to subdivide our cirrhosis patients into covert and non-covert hepatic encephalopathy, we see that the patients with CHE actually have prolonged saccadic latency. And again, they're more variable as well. The sigma, the spread of the distribution is wider. So it's delayed and more variable. And in fact, what we're revealing is kind of more of a quantitative measure of cognitive dysfunction rather than a qualitative measure. I mean, the psychometric tests basically just tell us you have covert hepatic encephalopathy or you do not. But what we're actually getting is a number of how delayed their reaction times are. And actually, if you look at the distribution, you can see mu along here. Ignore the y-axis, but basically you can see there's a long spread of everyone's different saccadic latencies. And what happens is that the normal healthy controls tend to be clustered over this side, and as you get more and more degrees of cortical dysfunction, they start to move down the graph this way. So the idea is that saccadometry, the measurement of these reaction times, actually is a better measure, a more quantitative measure, rather than just a simple test saying, you have it or you don't. It's like diabetes. You look at her blood sugar is much more valuable than actually saying, this person had diabetes, so do not. You want to get a degree, and the saccadometry is a good surrogate marker of the degree of cortical dysfunction. So here are the key points, the salient features to finish off with. I mean, there are large and significant differences in saccadic latency between patients with cirrhosis and patients with and healthy controls. But the key thing is that those with covert hepatic encephalopathy, when you use the current definition, actually have slower reaction times than those without. And in fact, what we see is this kind of spectrum of cognitive impairment in these patients. And it makes sense when you look at it. This is the digit symbol test. Essentially what the patient is doing is looking at a number, looking at the key, working out what I have to fill that in there, looking back here, drawing it in there, look at number one, look at the key, and they're basically making eye movements backwards and forwards, backwards and forwards. So it makes sense that if your eye movements are slower, you will do worse at this test. And it's true of all the other ones. So essentially we've found a better way of measuring it that's much quicker. I mean, psychometric tests take at least an hour to perform all of them, and it's longer and much harder in patients that take ages to do these things. Whereas the saccadometry takes 7 minutes to do a sufficient trial size and get a proper picture of their distribution. So we would suggest that a test of saccadic latency actually is a more useful and reliable marker of early cortical dysfunction in a liver clinic than actually performing all these different psychometric tests. And it actually has the potential to better inform treatment strategies. For example, it might be a good surrogate marker moving towards whether someone needs liver transplantation or whether they should have lactulose and rifaximin and so on, which are treatments for encephalopathy. And it also might be important for driving as well. I mean, these patients have been shown to have increased rates of car crashes. So whether or not that should be something that our DVLA in the UK or whatever regulating body is to take into account, one wonders. But basically, it shows early evidence of decompensation and allows us to act sooner. So, in summary, that's basically it. Okay, thank you very much.
Thank you, Dr. Any questions? Yes. Please.
Yeah, I also.
Dr. Wayne.
I think it's a nice study and as potential tool for the diagnosis of CHE disease. My question is any specificity with like you talk this tool also can use like a Huntington,
Mhm.
Parkinson.
Mhm.
So not only CHE, but between these several diseases, any difference? Let's say if you see SCORE, for example, SCORE2 for CHE, how about Huntington?
So it's,
SCORE1 or what's the
so
connection?
it's difficult to. The problem is that they're quite. How should I describe it? You cannot necessarily say a person's saccades are abnormal. Everyone's variable. Some people have slower reaction times than others. So there's no specific latency that is abnormal for someone. That's one problem. But what we can see is it's an early measure of that's all it is. Huntington's disease is an example you mentioned. I mean, the paper that I mentioned there. I mean, while it is interesting to pick up Huntington's disease early with saccades, I mean, what's the point? We have genetic testing. You know, it's basically play no role whatsoever. Parkinson's disease as well. Again, I mean, it's a clinical diagnosis still. Just because your eye movements are a bit slower, it is never going to determine whether a neurologist says or not you have Parkinson's disease. Another paper actually was quite interesting and actually looked at your recovery from general anaesthesia. And actually, as you become more and more alert, your reaction times speeding up as well. So it might actually be useful for saying, actually, this person's actually had a general anaesthetic in the morning and they're fit to go home and drive in the evening. Their reaction times are slowly, sufficiently recovered. So its use in Huntington's disease and Parkinson's disease actually I think is very, very good. This is why this paper in particular is so interesting, because it actually might have a role in this topic because the diagnostic tests for it are so useless. Okay, that answers the question. So it's difficult.
Yes,
Yeah.
yes,
Okay.
yes.
So a very good work. You did excellent job. This is a lot of work. How long it takes you to get 36 cirrhosis patients?
So it took us. Let's make it. So it was 2 years of.
2 years to get 36.
I think it was when I was an undergraduate. I started the pilot project on this topic, and then it started about 3 years ago now. I mean, 2 years of a third-year medical student attending clinics once a week. So I go to a cirrhosis clinic once a week for it would be sort of 10, 15 a year. So we were getting about two or three subjects a day, usually. 2 or 3 a day.
What is
in
that?
cirrhosis.
Alcoholic or what?
So that's a really interesting point, because actually we looked at all of them. Okay, and we intended to be alcoholic
Yeah.
and Hep C.
Sorry.
Yeah,
It's
particularly in the UK. It's predominantly those two. And actually, some interesting papers have shown that psychometric testing varies between the different etiologies of liver disease. And I must admit, I don't know huge amounts about it, but that is something that's a real future avenue for extending our study further, so get a bigger data set and look at alcoholics, look at the hepatitis, look at all the metabolic liver diseases and things like that, and actually work out if their reaction times change with those. So we couldn't really comment on it in our study, because it's only small study size, but that's one of the things. It's so difficult to get these patients. And the difficulty is that it's the psychometric testing. I mean, when I used to do it was sitting in clinic and getting these patients to draw these lines, and it is painful. It takes ages. And what I think, maybe because I've seen this test so many times, I think the ones you can often see the ones that are going to diagnose with CHE because they are so much lower. And if it takes an hour to do these 4 tests, and then we strap the lasers on their head, that takes 7 minutes.
Was there any incentive for the patients? Did they pay them?
Not really. I mean, to be honest, in the UK, clinics tend to wait ages to see a consultant anyway, so we just sold it as a way. You're going to be waiting anyway. Perhaps if it's okay with you, you could come do this. There was no incentive. Perhaps in theory we should have done.
Can you use this to, look at recovery from something like concussion? Like if you, football players or soccer players,
There is a body of work in that as well, and head injuries and things. And this chap here, it's a PhD student called Ben Pearson. That was his work. Was going to army hospitals and things and looking at how massive head injuries and things are actually linked to it, and people coming out of ITU and things like that, intensive care. So it has been used for that as well. So a big body of work in there. It's good. So So I'm just while saccadometry is a bit established field, the oculomotor physiology is an established field. This is the new part is the hepatic encephalopathy and how that fits in. But yeah, there's lots of reading out there for it.
Another question.
Yeah, please do.
How like ALS disease?
ALS.
ALS, yeah, muscle motor neuron disease.
So ALS, so the thing of motor neuron disease, it wouldn't tend to affect your extraocular muscles, would it? Am I right?
Yes.
But
then there's also motor neuron get that.
I'm not sure. For things like ocular pharyngeal, all the different myopathies may actually affect it. And actually, I don't know. But it's a really interesting point. I would have thought ALS wouldn't be involved because it's. Actually, it's difficult. No, honestly, I don't know. Things like demyelinating disease, I suppose, would make it slower. I mean, if you've got a big plaque of demyelination and the conduction speeds are much more prolonged, then I suppose if it's in the wrong area with that big pathway I showed before, it would obviously slow down your decision processes. But it's not something that's been looked at, to my knowledge. Right.
Thank you.
Thank you
Very nice
everyone.
presentation.